الله الرحمن الرحيم والصلاة والسلام على رسول الله. نبدأ اليوم part 2 uterine fibroid which is benign tumor of the uterus اللي قلنا سميناها myoma. Okay. Okay. ناخذ القلم ونبدأ بسم الله. لو تكلمنا عن medical therapy in general كده, it's the goal of medical therapy for myoma are temporarily reduce symptoms and to reduce the myoma size, and the therapy of choice of treatment is gonadotropin releasing hormone agonist which work as زي ما تكلمنا المرة اللي فاتت by down regulation. Okay, and it's an important medical therapy, and we will talk about it in general today. Any treatment that lower endogenous estrogen level should be effective, and therefore the use of aromatase inhibitor is another option. Aromatase inhibitor. Okay, this is another type of medical treatment. And medical therapy is provided pre-operatively. كثير من الناس يدوه pre-operative to improve the anemia, reduce the blood flow طبعا, reduce the surgical complexity of the tumor, and maybe it's better in recovery times. Prolonged medical regimen has traditionally been expensive and complicated. However, the introduction of oral gonadotropin anti-gonadotropin releasing hormone antagonists opened the potential for long-term use in fibroid. Similarly, there is a medical therapy for fibroid which is using selective progesterone receptors modulator, has become popular in Europe and in Canada where it's available. Currently, this is not available in Saudi and it's not available in United States. طبعا, if you talk to a surgeon, he would say that myomectomy, removal of the myoma, is perhaps one of the bloodiest gynecological operations performed, and most significant morbidity associated with its blood loss. There's a lot of blood loss in doing myoma. A variety of methods has been described to aim in the minimizing the blood loss. إيش هم الطرق هذه؟ The two main approaches are medical and mechanical to reduce the blood loss during myomectomy, diminish uterine blood flow to the myoma. We know that the blood supply to the myoma is highly variable, and it's difficult to predict the blood vessel located when dissecting the myoma. شوف الميوما هذه, this myoma is big. You don't know where is the blood supply to this myoma, but definitely very vascular. Whenever you cut here, you will find bleeding. If you cut here, you'll find bleeding. If you cut here, you'll find bleeding. This is why we have to make sure that we have something to do to reduce the bleeding. The anatomy can significantly be distorted by the myoma. You will not see the uterus as normal. Definitely, the major blood supply to the uterus may be altered, and the optional uterine incision to minimize the blood loss. The better one is anterior vertical incision. Anterior vertical incision. If you manage to get all the myoma from one incision, is better. This cut across the minimum of collateral channels and minimize the number of vessels. Posterior, what's the difference in anterior and posterior? We will talk about it, but posterior usually have If you leave it, it will have a lot of adhesion with the bowel and omentum. Anterior, usually, the adhesion is less than. One of popular medical approach to decrease the blood flow is in myomectomy is 8L-arginine vasopressin, which is called pitressin or vasopressin. Diluted solution of this injected directly into the myoma, raising the circumstances wheel and causing vasoconstriction. It's a good vasoconstrictive drugs causing the blood vessels to be constricted. Most investigators report using pitressin diluted 0.1 to 1 unit per millimeter of diluted using of diluents using a maximum of 20 units. Yani one vial like this is enough for the whole procedure. You don't have to increase the dose. Some feel that it's unnecessary, and that is only delay bleeding and does not blanch the tissue to provide better visualization of tissue. In our experience, if it's available, we always use it, and I found that it's really decreased the blood supply. Decrease the blood supply, yes, and maybe delay the bleeding later on, but before you close, you make sure that you are not leaving blood vessels that might bleed. Although the drug is not approved by Food and Drug Administration of USA, may have used it safely for a number of years, but it's not yet approved. Physician must recognize the potential side effect of this medication as for any medication, and it is contraindicated in patients with epilepsy, migraine, because it's causing more constriction. It's not good for asthmatic patients, not good for heart failure and nephritis, and any patient who have documented to have coronary angina or myocardial infarction should not have this medication. Myomectomy is rarely performed in such patients. Pitressin may produce water intoxication if given in high dose. An early sign which must be recognized: headache, drowsiness, restlessness, always proceed convulsion and coma, which can result from severe overdose of this medication. As I mentioned, 20 units is more than enough. You should not use more than 20 units. Definitely some people, they respond differently to different doses. The most direct method to minimize the blood loss by using myomectomy, to do a myomectomy, is a mechanical method, and that to decrease the blood flow. Many methods have been described using a variety of clamps, tourniquets, which apply the same general principle. This is called the Boney's myomectomy clamp, and it's very important that you put it in below the cervix or at the cervix level, where you actually obstructing the vaginal and uterine arteries and a lot of anastomosis in that area. The clamp is very easy and it's available. It's even available in our institution. It was first described by Boney that used an atraumatic clamp that compressed the uterine vessels and decreased the uterine blood flow. Boney clamp applied from the public end of the abdominal wound. It must contain a round ligament and in its grip, or it slipped below the uterine vessels. I tried to use it so many times, but I think pitressin and vasopressin is better than than mechanical clamp. Blood flow from infundibulous pelvic ligaments is compressed using ring forceps. The uterine blood flow is essential to stop. The location of the ureter must be known before applying any of these clamps. You have to make sure that you're not crushing the ureters. Ureter is just near this is the arteries, the uterine artery, uterine vein. The ureter is just here. So if you would apply your clamp here, you make sure that you're not taking the ureter, because if you took the ureter, then you will be in trouble. Other variety of methods use a clamp rubber band or tourniquet, and this is the tourniquet around them. Again, you have to make sure that your uterine artery, your ureter, you don't take the ureter with you in the clamp. Easy to apply, it's very effective. We do use it sometimes. The disadvantage using the tourniquet is that a small incision is often made in the avascular area of the broad ligament, although this does not have to be done. But if you want to work really nicely, you have to make a small incision here and a small incision here, and you put your tourniquet in the round, below the round ligament or inside the round ligament. What should we do? What should we do? Should we do Fanesteel, midline, Myron, John, Collins? These are the incision that can be done to remove the myoma. And I think it depends on the size of the myoma you are dealing with. We try always to do Fanesteel, and if we need to cut the muscle, we cut the muscle, especially in young patients. But in all patients and big tumor, we might go with the vertical midline. Fanesteel, this is a Fanesteel. You know how you do Fanesteel. This is Maynard, where you actually cut the muscles and cut the, so you will have a wider incision. Midline, and this is a midline incision, and it might be good for patients who have big myomas. This is one of the things that we use cautery sometimes in cutting the serosa to expose the myoma, and we reach until we reach the good plan, and then we dissect the myoma and take it out. This is a big myoma, but you can always try to feel it, and if it's a single myoma, multiple myoma can be taken from the Fanesteel. You can do Fanesteel, but in a big myoma like this, maybe you cannot remove it from a Fanesteel incision, so you have to go for midline, or like this one. It's almost impossible to take it from in a Fanesteel incision. This is maybe you have to open from xephosternum till pubic to get that myoma out. We mentioned that we should take the myoma from anterior incision. And if you take it from anterior incision, you try to go from the same incision to take all the myomas in that area, and not to have the uterus cut more than one incision. Sometimes you have to do that, but preferably if you can get all the myoma from the anterior incision, it would be nice. And this is how you close it. يسموها baseball, whatever, suturing. We said we apply clamp on the corneal structure here to cut the blood supply coming from the ovarian pedicle, and then the lower uterine segment and the bladder are usually dissected down to put your tourniquet if you want to put your tourniquet. This is your tourniquet. This is your tube ovarian and round ligament. Making the incision, yes, anterior incision, and then we reach to the capsule, and then we take the myomas, take the myoma out. After we taking the myoma out, preferably to suture the dead space, and then you do the cirrhosis. This is called the anterior and posterior. They go bony flaps, bony flap, where you take the myoma, and then this flap will attach together, so you will have a nice uterus after all, with no space. Huh? If you take the myoma, then you suture 2 to 2, and 3 to 3, and 4 to 4, 5 to 5. So you end by a nice uterus like this. Sometimes we do it if we have a nice single myoma posteriorly, and we don't want to cut posteriorly, so we cut anteriorly. We take the myoma and we flip the flap to this area. صور حلوة كده للبوني flap. This is bony flap. This is modify one, where it actually catch the anterior and posterior part of the cervix, so it will decrease the blood a little bit. But this one is better because it goes to the lateral wall and it cut the uterine arteries. Uterine incision, the lower the incision, the stronger will be in subsequent scar. كل ما طلعت على فوق كل ما كان السكار أضعف شوية. It is useful to mobilize the peritoneum and uterovesical fold and reflect the bladder down in the midline. A low incision peritoneal fold, which at the end of the operation can be used to cover the incision. So we actually put the peritoneum to cover the incision. That will make the healing better. It might have a disadvantage of adhesion of peritoneum in the anterior abdominal wall, but it's better than bowel adherent to the posterior wall. Midline incision, midline vertical, removal greatest number of the fibroid through the fewest incision. زي ما قلنا, if you can remove the all incision from one, all fibroid from one incision, it's better. The anterior wall adhesion is better. Posterior wall incision, 90% of the wall of anterior wall and 50% posterior wall. Posterior wall fibroid, deep intracavitary or subserous incision in the posterior wall, or fundal bony hold, like what I show you, where you go anteriorly and you take and it will be like a flap on top of the fundus of the uterus. Posterior fundal incision, inoculate all the fibroid. Interrupted suture in layers are used to close the dead space. Although you know that now when we do laparoscopic myomectomy, it will be difficult to do a lot of suture in the people. They just put a deep suture, and that would be enough. Extraserosal is sutured with fine stitch to the anterior surface of the uterus, and it's functional anterior incision. Posterior approach, but avoid posterior defect. Functional anterior uterine incision out of a posterior incision. يصير عندنا the number of incision has to be minimized. We have to reach the lateral tumor tunneling, creating a lateral myometrial incision within the initial central incision. The length should accommodate the diameter of the largest fibroid. And you have to avoid the three important things: ureter, uterine vessels, and cornea. These are the three things that might be affected by myomectomy. So you should be able to identify the ureter, identify uterine vessels, try to avoid them, and not to go through the. Currently, with a few exceptions, surgical treatment is preferred. طبعا if you talk to radiologist هيقول لك والله embolization is better. So if you talk to a medical gynecologist who doesn't like to go to operate in a bloody, he will tell you that medical treatment is better. But evidence-based surgical treatment is preferred for symptomatic uterine myoma until these new medical therapy are available and proven to remove the fibroid, decrease fibroid, and not to recur after stopping the medication. Uterine myoma is not only, the treatment is not only myomectomy, but as we mentioned in part 1, that it might be actually hysterectomy is the eventual treatment. The myomectomy is more common in our country than other, because people, they want to leave their uterus. Here we talk about short half-life of GnRH is due to rapid cleavage of bond between amino acid 5 and 6, 6 and 7, 9 and 10. I don't want to go into biochemistry because you had enough biochemistry in the last few lectures. By altering the amino acid itself, the position, you have maybe different properties, and this is the why substitution of amino acid at 6 replace the C-terminal glycine, inhibit degeneration, and this produce agonist. If you want to have antagonists, you have to change the position of other amino acid, and it will give you an antagonist. And maybe you have to increase even the number of amino acid, okay? Not only the one, but you might increase the number of amino acids. The initial agonist action is called flare-up effect. When you give somebody agonist, أول حاجة يصير لهم زي ما تكلمنا, all the receptors will go in, يديك flare effect. يعني الإفكت يكون very high. It's associated with increase in the circulation of FSH. This response is great in early follicular phase when GnRH and estradiol have combined to create a large reserve pool of gonadotropin. After 1 to 3 weeks, desensitization and downregulation of care of the pituitary produce hypogonadotropic hypogonadism or hypogonadal status. All the FSH-LH will be low. This is why the effect will be better. And you can see the flare effect here, بعدين down regulate, بعدين direct to suppress. It is very, very effective in suppressing it, but you have to be patient to 1 to 3 before the effect of the disease, of the medication. The initial response is due to desensitization or uncoupling of receptors from its system, whereas sustained response is due to loss of receptors by downregulation. And we talked about it the other day about these medications. عندنا the treatment of GnRH agonists summarize the experience with the GnRH agonist treatment of leiomyoma and then uterine side. It decreased uterine side من 30 ل 64%. This is after 3 to 6 months of treatment. The maximum response is usually achieved by 3 months. The first month, maybe nothing will happen. Second month, you start to see an effect. Third month, you start to have a true effect. A lot of study showed that 30 to 50% decrease after 6 months. Menorrhagia, anemia, pelvic pressure, urinary frequency, all respond favorably to GnRH agonist treatment, but you have to be patient. Gene-rich treatment result in reduction in uterine and fibroid blood supply as measured by Doppler ultrasound and microvascular density. A decrease in operative blood loss can be achieved when pre-treatment uterus is as large as 16 weeks or larger. And this is a very nice slide. You look at the option of treatment, medication, oral contraceptive, progesterone, non-steroidal, something to stop the bleeding, etiological treatment like gnRH and progesterone, progesterone receptors modulators. The definite treatment is doing a hysterectomy. Sometimes we do laparoscopic myomectomy, sometimes we hysteroscopic myomectomy, sometimes we do myomectomy. Non-surgical alternative, and this is, we will talk about it in now, uterine artery embolization and fibroid ablation. However, some studies find no benefit in terms of surgical blood loss, length of stay in hospital, and surgical dissection may be more difficult because of softening of myoma. And I found this is true. Patients who have taken medications and then they come to have myomectomy, the myomectomy is usually more difficult, although it may be smaller size, but it's more difficult than a virgin myoma. Where is the variation in response when one consider the many factors involved in myoma? ترى عندنا progesterone, estrogen, growth hormone, receptors هذه كلها they are available, and every myoma will respond differently. It makes sense that every myoma is not the same. After cessation of gene-rich therapy, means after 4 to 10 weeks, the myoma and uterine side return to pre-treatment level after 3 to 6 months. And this is why a lot of surgeons, they do not prefer, because you're just delaying the surgery for 6 or 8 months or a year. The rapid regrowth is consistent with the fact that reduction in size not due to cytotoxic effect. The shrinkage is usually due to loss of water and extracellular matrix. Preoperative gene-rich agonist therapy offers several advantages, especially in hysteroscopic removal of a submucosal fibroid. And I told you yesterday, that part 1, that hysteroscopy can be done easily in patients who have pedunculated submucous fibroid. But if the fibroid is having the uterus and having the myometrium, maybe it will take 1 or 2 or 3 sometimes sessions before you remove the whole myoma. To decrease the myoma side, make the endometrial atrophy, improve visualization, and decrease vascularity will reduce the blood loss. And I believe that if you are going to do a hysteroscopic removal of a fibroid, medical therapy is maybe better in those patients. It's better than, but not for an open myomectomy. Leiomyomatosis veritonized, disseminated. This is a condition which is multiple small nodules of benign smooth muscle are found throughout the abdominal cavity and occasionally even in the pulmonary cavity. This condition appears to be very sensitive to estrogen and progesterone because it has been aggravated by postmenopausal estrogen therapy. Regress has been achieved by gene-rich treatment. And it's very difficult to treat, difficult to diagnose even. It will be like small nodules like this. And if you see in the peritoneum, a lot of myomas, this myoma, this is the myoma. And this is why small myoma, and you can actually take them from, you can take the myoma, make the diagnosis, and then start them on therapy. Adenomyosis. Adenomyosis is an ectopic presence of endometrial glands. Endometrial glands. هناك في صور غريبة كده بتطلع، شافتها؟
لا ما احنا شايفين شيء.
أنا شايف واحد كده طالع ما أدري إيش بيسوي. I don't know who's he. بس فاتح الكاميرا. منصور عسيري ده شكله. قفل الكاميرا يا منصور. Adenomyosis is an ectopic presence of endometrial glands within the myometrium. Within the myometrium, and this is a normal uterus, and you can see that the other one is a non-normal uterus with adenomyosis. Adenomyosis look like this when you cut it. It's a fleshy tissue. It's not like a fibroid. You can easily diagnose it by naked eye. The diagnosis can be made by magnetic resonance imaging, MRI, and successful treatment, very successful treatment with GnRH. Although the definitive treatment is removing the uterus. Side effect of GnRH, hot flushes, experience more than 70% of patients because they are actually make them menopausal. After a few months of GnRH, you'll find that they come for 75% complaining of the hot flashes. And approximately 5 to 10% have complained of headache, mood changes, vaginal dryness, joint and muscle stiffness, and depression. All are due to hypoestrogenic status. About 30% of patients continue to have irregular bleeding, vaginal bleeding. It is useful to measure the circulating estrogen, and if the estrogen is low, suppress inadequate, then a small number of 10% will experience localized allergic reaction at the site of the injection. More serious reaction with immediate and delay anaphylactic can occur, require intensive support. These are rare complications. Bone loss with GnRH is well known, and this is why there is what we call add-back hormone therapy, where you give them hormonal therapy to prevent osteoporosis and bone pain. A significant vaginal hemorrhage, 5 to 10 weeks, encountered in 2% of treated patients. Before degeneration, necrosis of submucous myoma. The disadvantage of agonist treatment is delay in the diagnosis of leiomyosarcoma. Keep in mind that almost all leiomyosarcoma present as the largest and only uterine mass. And this is why keep in mind the leiomyosarcoma before you start your patient into the medication. Close monitoring is necessary, and surgery has been recommended when either enlarge or shrink occur with GnRH agonist treatment. The use of Doppler ultrasound MRI offer a great accuracy for evaluation. However, the incidence of leiomyosarcoma occur قلنا أقل من 0.5%, almost to occur in premenopausal women. Premenopausal women, conservative approach is warranted. Escape of suppression can result in unexpected pregnancy. No side effect of fetal exposure of GnRH. And if you give GnRH and then the patient got pregnant, or she was pregnant, there is no side effect for exposure in people who are exposed in early weeks of pregnancy. GnRH and steroid add-back. Well, the treatment of GnRH with steroid add-back have been developed to permit what we want to do. We recommend 1 month of GnRH treatment followed by treatment combined with daily continuous add-back estrogen, progesterone, whatever regimen available. In the view of the sensitivity of myoma tissue progesterone agent, makes sense to keep the dose of progesterone relatively low. Preoperative GnRH agonist treatment is not indicated in every patient with myoma. The best candidate for treatment are women who have bleeding or to allow for response of iron supplement, or the surgeon clinical judgment suggests that reduction in size may influence the choice of treatment. يعني ممكن يقول والله نسوي لها laparoscopic, نسوي لها vaginal hysterectomy instead of doing laparotomy for to remove the uterus or to remove the myoma. So treatment of a GnRH agonist or antagonist, treatment of suppressed pituitary without initial flare-up. هذه حلاوة الانتاجونست is more expensive. And there no good evidence that it can be used for a long time. But definitely, if you give the antagonist, it will stop the GnRH immediately, so you will not have a flare-up response. The initial result of Debo treatment, pre-operative treatment for uterine fibroid, were similar to those with GnRH agonists for long treatment, for long time treatment. Agonist means that you have to give only for 1 month or 2 months, while GnRH agonist, you have to give it for longer time. More recently, a placebo-controlled trial showed that the treatment of GnRH antagonist combined with adverse result is significant reduction of heavy menstrual bleeding in perimenopausal women with fibroid. And this is very, very important in patients who have bleeding. Like we see sometimes patients with fibroid with hemoglobin of 4 or 5 or 6. I think those patients, they should have medical treatment till they get better in their blood picture, and then to be assessed for myomectomy. Hot flushes were the most common side effect. Add-back therapy with combination of estrogen will help them. The dose be higher one that you currently approve for the use treatment in endometriosis. Sometimes fibroids are associated with endometriosis. Treatment with mifepristone. This is the progesterone antagonist, effective reduction in the size. The initial study was relatively short term, 12 weeks. Fibroid shrink was observed of dose 20-25 milligram daily. Lower dose is effective without high rate of hot flushes. Advantage كثيرة. In 6-month study, 5 milligram, 45% reduction in uterine size, decrease in pressure symptoms, increase in hemoglobin, non-significant increase in hot flushes. Similar reduction in uterine size observed in 3-month study of 5 milligram dose, improvement in pain and bleeding. However, long-term treatment will result maybe in endometrial hyperplasia and consequently of anti-progesterone effect of the drug. Like we mentioned yesterday, that some of these medications have two effective. They have a receptor in endometrium completely different than receptors in myometry. The endometrial effect make unacceptable choice for ongoing treatment of myoma with the large clinical trial and performance established safety. Short-term treatment before surgery has been tried in selective progesterone receptor modulator is successfully reduced the size of the problem and has increased use of the treatment, the fibroid associated with this. Data available in a lot of trials show that endometrial changes were present in 70% of patients during the treatment. However, these medications are not available in Saudi Arabia and in the United States. We have something available here, treatment of myoma with use of Mirena, levonorgestrel releasing intrauterine system. When uterine enlargement because of leiomyoma is no greater than the size of 12 weeks, the insertion of myoma of the IUCD followed by decrease in uterine size in many but not all patients with a dramatic reduction in blood flow with about 40% of achievement in MNB. So نحن هنا because release it's progesterone, so it antagonizes the estrogen and it's local effect and it's very effective. The contraceptive effect is not diminished, but the exclusion rate is high, the expulsion rate is high. This method of treatment is not recommended when distortion of uterine cavity is evident on examination or by ultrasound. The beneficial effect of local applied progesterone is unexplained, contrasting within the study that indicate growth promotion of myoma by progesterone. It's likely the function of endometrial suppression rather than the direct effect of fibroid. عندنا treatment to uterine artery embolization. Radiologists believe that we are very aggressive, removing tumor, benign tumor with a lot of blood. And they say that we can treat all the myoma by radiological intervention. It's a procedure which can be done under local anesthesia, take about 1 hour, 45 minutes. A catheter is advanced from the uterine artery, as you see here, until you reach the uterine artery and other branches, going to the fibroid itself, and then injecting polyvinyl particles of gelatin microspheres to occlude the blood flow. So you're just making a clot here, which causes myoma undergo necrosis, of course, if there is no blood supply, and transit ischemia, but normal tissue generate fibrinolysis and survives. The procedure is not recommended for larger fibroid. After 5 years, recurrence is about 10 to 25%. Most patients experience a severe pain, and I have seen we do this procedure in our hospital, and usually they are a patient admitted under the consultant, gynecology consultant, and then the radiology will do the job and go home, and the patient start complaining of pain, nausea, low-grade fever, high white blood count, and sometimes they stay in hospital for 1 or 2 days from the severe pain, and they have to have medication. In addition, serious complications occur, including complication related to hysterectomy, amenorrhea, premature menopause, septicemia from uterine infection, bowel obstruction, pulmonary embolism. These are serious side effects, but it's rare. Several deaths have been reported, giving the rate comparable to that of hysterectomy. A significant number of patients with large myoma acquired intra-abdominal adhesion. Nevertheless, the fertility rate and complication after the pregnancy is achieved are not known with the certainty. A randomized comparison with the myomectomy indicated a higher rate of fertility and miscarriage after embolization. Last year in the Saudi Society, there was a case presentation, and the doctor who presented show a very good rate of pregnancy after embolization. But as a rule, usually we do not prefer to do this procedure in patients who wants to get pregnant. This is a nice slide showing how the catheter goes to the uterine artery and where is the particle occluded to prevent blood going to the uterus. Treatment with ultrasound, MRI mapping system can be used to visualize direct high energy ultrasound to destroy myoma. The temperature achieved reduce thermal injury, skin and potentially side effect. MRI guided focus ultrasound approved to treat patients who desire fertility, given that it's not associated with increased risk of spontaneous abortion or placental disorders. Data on successful term pregnancy after this procedure appear to be comparable to other surgical options. And this is how they do that. They magnify the, I'm putting a target here for the myoma. Focus ultrasound energy will be given far from the field, right? And don't destroy them. And this is the treatment target. This is the ultrasound transducer. The transit ischemic can be produced by placing a vaginal clamp. This is very interesting. In the vaginal fornices guided by ultrasound to clamp the uterine artery against the cervix for about 6 hours. So you put the clamp and you leave it for 6 hours. Short-term studies have demonstrated efficiency and comparability to embolization and long-term recurrence, reassurance. I think maybe this is my last slide. I'm sorry I took a long time, but and I will see if you want, if there is any questions, I will be able to answer. For endometriosis, what is the best treatment option for infertility? Very interesting. Adenomyosis طبعا usually occur in multiples rather primates. So whoever have an infertility, usually they are of secondary infertility. But if it's a primary infertility, I would think that she should receive medical treatment to decrease the size for 6 months, and then she go for trial according to her status. If she has nothing except the adenomyosis and the uterus getting smaller, maybe she will get pregnant by induction ovulation if her induction is not good. So Altani, regarding embolization, what is the recommended size of myoma to do it? The embolization, most of they prefer the smaller one and they give better result. But I've seen people taking myoma up to 15 centimeters. نحن as a surgeon, sometimes when we have a recurrent myoma, سويت لها عملية بعدين تخاف انك تفتحها ثاني مرة تكون ترسلها للامبولايزيشن. In those cases, they take in size, but the recommended size is less than 15 centimeters. Why, doctor, is more common? Why it's more common in multigravida? It's not more common in multigravida. بالعكس كل ما حملت الست أكثر كل ما قل نسبة الفايبرويد. Usually it's الليبرس أكثر من المالتيبرس. Previously, mode of delivery was to allow vaginal delivery if we did not enter the cavity with myomectomy. Yes, this is the old school, but I think today anybody who have a myomectomy, the doctor will give her the choice, the better choice. He will tell her the better choice is to do a cesarean section, to have a cesarean, whether the cavity is open or not open. Adenomyosis, adenomyosis, What is you mean? Yeah, adenomyosis. You treat adenomyosis and then you go for normal pregnancy. If not, you do use IVF, ICSI, whatever you. What about now? Well, this is what I'm saying. Now a lot of doctors will prefer to do a cesarean in patients who have previous myoma, regardless of they open or they don't open scar. What is the indication of hysterectomy in patient with fibroid? All cases of fibroid, they should be treated by hysterectomy. Okay, this is the indication. Like because people they don't want to lose their uterus, this is why we do myomectomy. So that if a patient we cannot do a myomectomy, then we go for hysterectomy. There is no direct indication, like I'm saying, if the uterus is bigger than 15 centimeter, 20 centimeters. Sometimes, if it's 20 centimeter and a single myoma and it's vinculated with subservice, maybe the uterus will be completely normal. So it depends on the size of the myoma. What is the best treatment for multiple small myoma? Medical treatment. Well, medical treatment, yes. We have appreciated of effort. Why in adenomyosis more common in multi patients? Because every time she gets pregnant, some of the tissue, some of the endometrial tissue will enter into the muscles and stay there. This is why the more pregnancy, the more likely to have adenomyosis. If previous 1 centimeter, one cesarean and one myomectomy, is it possible to give her a trial? Generally, no. I will not give her the trial. And I treat myoma, I treat myomectomy like cesarean, like a previous cesarean. If you have one cesarean and one myomectomy, كأنك مسوي two cesarean, and it's better to do cesarean for that patient. What will we do with a big broad ligament fibroid? Surgery. Broad ligament will not be affected by hormonal therapy. So it's better to remove it. What is the time to return to fertility after treatment with GnRH? After the cycle, and if you give them medication, usually they stop their period for more than 3 or 4 months. Once she starts to have a period, you can start immediately treating her infertility. So whenever she has first period after the injection. Is the infertility after embolization permanent? There was a study where they could achieve pregnancy after embolization, but we don't have a lot of data. Can fibroid become infected? Yes. And if it's the management is antibiotic, and once it's subside, then you might offer that lady myomectomy or hysterectomy.